So good noon to all of you. I assume some more people will come in. The other session, the plenary session, lasted till 12:30, so it requires a couple of minutes to come to here. But the introduction anyway is just 1 minute. I'm Philip Poortmans, radiation oncologist working in Antwerp in Belgium. Warmly welcome you here on behalf of S.I.T, Sordina Intraoperative Radiation Therapy Technologies, and I have the pleasure to co-organize with Fabiola Paggiar from Pisa in Italy, radiation oncologist, and Giuseppe Felici from Aprilia, nearby Rome, from S.I.T, this symposium. Now, this satellite symposium is about how to go from low energy, low of course is relative, let's say that it is not very high energy electrons, but low energy electrons to the first clinical applications. What do we have? What is the clinical scientific awareness? And what are the possible hurdles to arrive there? So this is the program. The welcome is hereby done. I will start with how to make the transition to the first clinical applications using a low energy electron beam flash generator. These are my conflicts of interest. The most important is the lowest one, because since the 24th of February 2022, I always include a slide about the madness of the wars, and it's not getting any better. And soon this will be 4 years that in all my presentations I include a word about this. Scientific awareness. So this is something of the good news, because when I did this search a couple of days ago, I was positively surprised. If you look in just PubMed to make it easy, and you just type in flash radiotherapy, you get an increase in publications, especially the last, let's say, 10 years. But as yet, it doesn't stop to increase. So if you look that in 2021, we exceeded the 100 publications in a year for the first time. Since then, every year, a number of extra publications are coming in. So this means that there is still a lot of attractivity in this field. A lot of people are working in it. And then something I found quite amusing, if you look in some of the articles, what you see coming back every time, an emerging approach, a new technique, promising, innovative, the potential to. So it's already some years in the face of, it's very promising and we need to invest in it, but I think we need to get going. And I very much liked the first presentation of Kostas, where he clearly said that currently the most hampering to going to real clinical applications is having the dedicated devices. If we take a look at clinical criteria, how to select patients for flash radiation therapy, especially focusing here on low energy electrons, well, these are, let's say, the cancers with relative survivals. So, of course, we all know that prostate and breast have an excellent relative survival, while some like lung, liver, but also pancreatic cancer have a very dismal outcome. So we could focus on those with poor outcomes, identifying the challenges. Is it more local control or is it more distant metastasis? How can we improve cure? By combining the treatment with other forms of local treatment, surgery, other forms of radiation therapy, with systemic therapy, and the upcoming immunotherapy, of course. And in some of those occasions, it's not yet about cure, it will be about palliation. Nice example is pancreatic cancer. In the good outcomes, I would not focus too much on that, I come back to it, but we can still lower treatment burden. We have very low-risk breast cancer patients who, after some years, have some deformity of the breast, some asymmetry, need a correction, surgery at the other side because of the asymmetry. And in intermediate, it's similar. How can we balance the optimal treatment towards cure and lower the burden? Now, of course, when we speak about low-energy electrons, apart from the superficial tumors like skin cancer and some superficial other tumors, we have the ESTRO recommendations on intraoperative radiation therapy. And for some of you, this is not new, to give this a kind of personal appraisal, this is a model which exists already for many, many, many years, which has to do with how much energy do you need to put in achieving something and what will be the contribution. So if you have, for example, a bread and butter, that means it's easy to achieve, low input of energy, but it doesn't contribute a lot. You don't do this for itself. While you're doing it, you could include it. Breast, partial breast irradiation, skin cancer. The pearls is what we are all looking for. There is not too much of an investment because we are already having applications that are similar but not flash, and possibly the benefit is high. Pancreatic borderline, unresectable, high-grade brain tumors, locally advanced, and maybe I could add here now recurrent tumors because more and more data are coming back are being published on that. And then the difficult to achieve but potential real game changers is some recurrent tumors and pediatrics. So what are the caveats and the pitfalls? Now, strength is that we have quite some solid preclinical evidence which is still growing. It has led to a complete revival of radiobiology, of which I'm very happy. When I did my residency training, it was all about radiobiology, and then it completely went down, and radiobiology was something nearly completely neglected. Only the basis was still there. But now radiobiology is really on high levels again. Quite some very good teams are involved in research on FLASH. It's an appealing topic, as shown by the publications. Good working groups, organizations, congresses like FRPT, and it's not only for the low energy electrons, it's also for other technologies. Now, the weaknesses is that we still don't know everything. And yes, that was discussed this morning by Kostas, that do we really need to know everything before we can apply it? Probably no, probably not. But we need to learn a little bit more about optimal physics settings, how to translate it to clinical applications, and indeed, as said this morning, dedicated machines. Opportunities is that the market is clearly growing. Look at the exhibition. Very high energy electrons, which exist for decades, let's be honest. But now it gets a boost in investment because it might be, like Costa said also, an ideal approach for FLASH. And reducing the number of fractions is anyway appealing. Some departments are now all patient indications confounded already way below 10 fractions of treatment per patient. Head and neck, lung, breast, everything included. So we are in that direction. The threats is that, as also said this morning, indeed, some clinicians are absolutely not interested. It's something which is a kind of hype managed by few people and which will go over. And in especially some countries, and human beings are similar everywhere, the reluctance to change. So what are possible pitfalls? That's fractionation. For early murine skin reactions, if you give single fraction doses, flash and conventional, you see a clear sparing. If you do it with 2 fractions, 4 hours in between, it's already, 4 fractions, sorry, it's still present, but it is smaller. If you go to more fractionated, your flash protection effect gets lost. And similar, it's not completely similar, but very much, same endpoint that when you start giving multiple beams. With 1 beam, you can have the full effect, but if you split to 2 beams, maybe it still works like shown at the left. At the right, it's a 3-beam arrangement where you see that the flash effect gets lost. So concluding, this is from a nice, very recent publication from MCAT, Pierre, Paula, and Charles, showing that in a lot of what we currently do for cancer approaches, that the flash can contribute, sometimes as a big change, sometimes as a small change. For example, a radiation therapy fraction lasts 15 minutes. Whether you give the radiation therapy itself in 1.5 minutes or 1.5 seconds will not change that much because patient positioning takes most of the time, but nevertheless you can spare and lower the burden. And then my last slide, and introducing Fabiola Pacciar on the second topic, shows the picture of the CHC Flash Prime, which is the first CME accredited flash medical device. Thank you very much. Fabiola, all yours.
Good morning. Thank you, Phil, for the kind introduction. And I'm going to show you the experience on flash of our center in Pisa, named CPFR, Pisa Center on Flash Research and Implementation of Flash Radiotherapy, particularly in the issues related with clinical trials and patient selection. This is my disclosure. Before moving into the heart of my presentation, let me briefly highlight what we know today about flash. We know that it is a biological phenomenon characterized by normal tissue sparing effect and comparable tumor control. And this phenomenon can be triggered when specific beam parameters and the threshold are met. And so few things, but at the same time give us a snapshot of the challenge related with flash and with its clinical translation. In fact, by the technological point of view, for example, such high dose rate beams are very difficult to generate in a stable controlled way. By the dosimetric point of view, standard detector usually saturate at ultra-high dose rate, making accurate measurement very difficult. And finally, by the radiobiological point of view, flash effect is a completely new phenomenon, completely different from the effect that we have learned with conventional radiotherapy. So, few things, but we can see that flash radiotherapy has a great opportunity, but at the same time has several challenges that we have to approach with rigor and caution. In my opinion, to investigate the flash effect and to overcome the several challenges related with this topic, 2 are the main requirement. One is a multidisciplinary team, and the second a dedicated LINAC for ultra-high-dose beam. And on the basis of these 2 pillars, 5 years ago, our center was born, and in 2022, our LINAC was installed. This is electron flash built by S.I.T. Sordina following our specific requirement, in particular a triode gun-based technology. Triode gun means that we are able to change one key beam parameters at a time, keeping on changing all the other, and we can switch from conventional to high dose rate beam without change the experimental setup. So this system, this platform allows us to systematically assess in-depth flash effect, minimizing experimental errors. More recently, we update our platform with a microtaxity for in vivo experiments, thanks to a funding grant from PNR project. And here you can see our main research line. One related to basic research to investigate the radiobiological mechanism behind the flash effect and to acquire important propedeutic data to develop a clinical device, in particular able to produce very high energy electron beam to treat also deep tumor, and to optimize the clinical application of the already available device with the low energy electron. And the second line of research is related to clinical trial. We are also investigating the combination between mini beam and flash. For this purpose, we develop a platform where we are able to combine flash and mini beam, and we are able to adjust independently the time-related parameter of the flash with the spatial one of the mini beam. So, before speak about clinical trial, we have to keep in mind that flash radiotherapy is not yet universally applicable. So early trials are very important because will define and reshape the credibility of the field flash. So the main goals when we design a clinical trial in this area are to maximize safety, but at the same time, reproducibility and scientific robustness. And to acquire, to reach this goal, we have to design a trial with a highly restricted patients population. We have to choose simple and measurable endpoints, and obviously to reduce any variable or confounding factor. For this reason, we decided, confident in the robust, consistent result from other research groups from our own in vivo experiment, to move forward the clinical trial to test the flash effect in human. And we focus on non-melanoma skin cancer because it's a type of cancer suitable for the treatment with low energy electron beams because it's a superficial tumor, and at the same time is a very common cancer, and so allow us to collect a statistical significant study sample easily. And finally is a type of tumor in which radiotherapy plays a significant role, and so flash radiotherapy could have a clinical impact. We included only T1 and 0, and this because this stage of disease is suitable for a single fraction treatment. On the other hand, bigger tumors such as T2 and more need larger volumes and require usually fractionated irradiation. So including all the stage of disease means to have several confounding factors, in particular volume effect and fractionation. So we decided to focus only on T1 and 0 tumor. Another important point that I'd like to highlight is that our LINAC, as other LINAC from other company, is not a clinical device, only a research device. So we have several challenges that we have to overcome to use it in the human. First of all, we have to acquire a specific authorization from the Ministry of Health, and we have to prove the safety and the essential performance of the device. And second, we have several technical problems to solve. For example, to treat the tumor with a different dimension, we have to use applicator with different diameter, but change the diameter means change also some important key beam parameters related with flash effect. And different diameter have also different length of the collimator, and disease could lead to some problem in the setup patients, including the risk of collision. So, to avoid these two problems, we decided to design and develop a dedicated dose shaper, just mountable on a 7 centimeter applicator, so all the patients will be treated with the same applicator without change the key beam parameters, and adjusting the dimension, the shape of the field, just moving the leaf of this dose shaper. Another problem is the patient setup, because electron flash LINAC could move only through 3 fixed positions, so we need a system with a more degree of freedom to position a patient properly. At the moment, we are using an homemade solution, just a patient height adjustable and tiltable treatment couch, waiting for more sophisticated systems such as a dedicated robotic chair. Another limits for the clinical translation also with low energy electron is dosimetry, because all we know that at the moment we have a lack of clinical dosimeter and a lack of clinical dosimetric protocol. Nevertheless, we have achieved an accurate dose measurement using some detectors that we develop directly at our center, and using together to other detectors provided through collaboration such as flash diamond, calorimetry, and so on. Another point is the development of the TPS, so we are able to check, to collect distribution of the dose, and this TPS was developed together with a colleague from Roma La Sapienza University, and we are working also to implement this TPS with the threshold of the flash sparing effect of flash to generate an MBA-weighted DVOH. And finally, this is our clinical trials. This is a randomized phase 2 clinical trial to compare ultra-high-dose rate radiotherapy and conventional radiotherapy in one fraction in patients with E1-0 non-melanoma skin cancer unsuitable to surgery. All the patients will be undergo to a CT scan and a TPS, and will be treated with the same LINAC machine for a total dose of 22 gray. The primary endpoints are safety, measured as skin toxicity, and obviously efficacy measured by a local control rate. All patients will be followed using also advanced imaging technique as ultra-high frequency ultrasound, LC or CT, and obviously biopsy. So, summarizing the main highlights of our trials, maybe they are the use of a dose shaper to keep unchanging the most important key beam parameters related with flash effect, the use of a treatment planning system that is very important not only to treat safely patients, but also to collect important data about the correlation between dose and response. The use of the same machine, so we are able to treat patients with the same beam quality energy spectrum, reducing the bias in dosimetry and radiobiology. The use of a very selective patients population to avoid some confounding factors, in particular fractionation and volume effect, and finally an accurate follow-up to acquire in vivo clinical and radiobiological data in human of the flash effect. In conclusion, skin offers a clear and controlled model to evaluate flash radiotherapy compared with conventional technique. Moreover, it allowed to control and measure oxygenation, and all we know that oxygen plays an important role in flash effect. Squamous cell carcinoma and basal cell carcinoma are lesions usually well-defined, making them particularly suitable for precise high-dose irradiation, and flash radiotherapy could improve comfort of a patient with no melanoma skin cancer, reducing treatment time. And we have to keep in mind that most of these patients are elderly and they have a lot of logistic problem, and obviously decreasing the rate of risk of injury. But we have some concern. For example, elderly patients may show reduced flash benefit, but at the moment we have no enough data. And finally, healthy skin remain important organ at risk when we treat deep tumors with very high energy electron device. First, to finish, I'd like to thank all my colleagues involved in CPFR, because with their hard but enthusiastic work made all this possible. Thank you, and thank you for your attention. Now I introduce Giuseppe Felici for the technical challenge pitfall in flash.
Thank you very much. I'm Giuseppe Felici. I am an S.I.T. employee, as some of you may already know. What I would like to share, okay, sorry, who knows me knows this slide too, but even though it's been updated in the last years, our idea is that flash is such a complex and a potential revolution that requires, let's say, a three-step process, starting from basic research, moving to the first clinical transition that is IOeRT and dermatology, up to VHE. And we would like to walk all this long walk, having the science as a guide and technology development as the effect. So what I am expected to talk you about is the new flash IOeRT unit, CHC Flash Prime. But instead of, let's say, bombarding you with all the data and information, I would like to have a different approach. Let's discuss together why we have designed this unit like that, and what are the potential pitfalls that we have decided to fight and to avoid. Let me remind you that the system works in two modalities, flash and conventional. There are two energy, and the average dose rate is 300 gray per second, and these are the PDD as you can see. And the PDD are the same both in conventional and in UHDR modality. So what are the pitfalls that I would like to point out? There are both flash-related pitfalls and not flash-related pitfalls, let me say that. So what are we discussing about? Well, the first thing to keep in mind is that we don't want, if I may quote Hegel, let's say, flash cannot be the night in which all chaos becomes black. So we need to identify precisely what are we talking about. So we need a clear ultra-high dose rate identifier, that is, what's the dose per pulse, what are all the rates, and all the beam parameters. Otherwise, we do not see what we are talking about. And let me remind you shortly what are all the physical observable we must keep in mind. From the time of a single pulse to the time of irradiation, all the possible rates, average, instantaneous, and the dose per pulse, and the total dose, the dose per fraction. What does this mean in the specific case of an IOeRT or dermatological treatment? So we need to know the time of a pulse, of a single pulse, the dose per pulse, the number of pulses, the pulse repetition frequency, and, in case, the delay time between two subsequent irradiation. And this information univocally identifies the temporal beam structure of the beam we are talking about. There is another pitfall that is pretty dangerous and that we should agree about what does monitor the beam means. Beam monitoring for a medical linac is not measuring with an external device any aspect of the beam. Beam monitoring means having a system integrated within the machine which is capable of measuring, elaborating, and displaying the data to the final user. This is pretty important. What does this mean in the specific case? I am using, let's say, in this case, the HMI of our research machine, where all the temporal beam structure can be changed. If you want to change each of the parameter of the temporal beam structure, now it should work. You can, in this case, but this is the research unit, you can change the time of a single pulse, the duration of a single pulse, the dose per pulse, and then there is a system that for each pulse measure with two independent channels both the dose of a single pulse and make the integral. And a monitoring system is also capable, well, this is the International Electrotechnical Committee definition, must be capable of terminating the irradiation when the accumulated dose has been reached. So this is what we're talking about. We're talking about the possibility of proper setting the machine, properly controlling and displaying all the information needed. In case of a medical device, obviously, there are much less degrees of freedom because the temporal beam structure will be fixed and according to the one that has been validated in order to have the clinical compliance of the system. As an example, the value of our machine will be 2 gray per pulse, a time duration of 2.5 microseconds each pulse, a PRF of 150 Hz, and that leads to an average dose rate of 300 gray per second. So in this case, the HMI is much simplified, but still, okay, I hope you could see, here on the left, there are all the relevant parameters that are properly set. The final user cannot change them, but can check and verify that the treatment has been delivered as the program wants. So the first pitfall I would like to point out is the issue of a proper identification of UHDR modality and the monitoring. The second issue I would like to point out, it's not flash related, but still it's a challenge. That is conformality. Conformality, what does this mean? I mean, flash effect alone isn't enough. Conformality matters. And this means not only in terms of a geographical miss, that would be a big issue, but also in our skill of properly evaluating and processing the information about how the target and the organ at risk are irradiated. As long as flash effect is triggered, I don't know exactly by what, so but I mean, it's triggered by rate, pulse. We must know precisely how our organ at risk, okay, the laser pointer, no, our organ at risk is irradiated at what rate, with what pulse. So here there is a need of new tools beyond the classical one, beyond the dose volume histogram, including those rate volume histogram, but also the capability of doing all that. Well, the good news, well, sorry, okay, we should already know, I mean, the staff in Lausanne published this paper several years ago. I mean, what happens if we do not calculate properly the dose deposition? Okay, so this is well known in literature, but the good news is that we have developed a specific solution that works also within the FLASH framework. We have a system capable of performing imaging, FLASH planning, that is a planning that is not only conformal, but also takes into account the FLASH modality, image guidance, and treatment validation before the treatment is delivered. So the unit has been designed in order to be first to let the clinical community avoid all these possible and potential pitfalls, and also offer a good usability in terms of dimension, weights, movability, and radiation protection performances. I would stop here, just 20 seconds more than expected. Thanks. And now we would be, we would like to have a question and answer session. So please feel free to ask whatever. We're here for you. And after that, which lasts 20 minutes approximately, we will communicate who is the winner of the FLASH MD Be the First contest that was launched in Vienna, Estro, last May. Thank you. So we are here for your questions.
Okay, just to moderate the expectations, the discussion will be about 10 minutes because Giuseppe lost track of time. And at 1:30, there is the next session here. Okay. Before Pierre has the question, I will ask it to you. You made the choice for the clinical machine to 2 gray per pulse. While quite some investigators are propagating for, if possible, everything in 1 pulse. What's the philosophy behind it? Is it something which can be adapted in the future, etc.?
Oh, you have asked such an easy question. This is, let me say, the question. First of all, we have used this 2 gray per pulse because it was the outcome of a preclinical radiobiological campaign performed with the Institute Curie that shown that in this condition the irradiation offers several advantages and it's causative. Nevertheless, we don't want to say this is the optimal value. There is a lot of room for future investigation. And yes, from a technological point of view, it's possible to deliver higher or even lower dose per pulse. There is a big question that everybody should ask herself or himself, is that we must find the balance between the highest possible dose per pulse and the safety issue related with the dose delivery consisting in 1 single pulse. And also, let's say the higher the dose per pulse, the higher the risk associated, the more demanding the monitoring and also, let's say, the regulatory part. I hope
This is completely consistent with what was said by Schuller this morning, that if you indeed give everything, for example, one pulse of 12 gray, and then the machine is, nothing is perfect, gives a second pulse within the same moment, then the patient receives indeed double dose, and there is no way to compensate for that. So it might be a safe approach, but it is something which is adjustable in the future depending on the evolution of the technology. Other questions or suggestions? If not, I have a question, Fabiola. How would you think, would you expect an accrual for the trials that you're setting up in skin diseases, in skin cancer? Because what we would love to have, of course, is not only enough data on enough patients, but also we want to know them yesterday. And in skin cancer, one of the benefits is that you have a visible disease in which you can just with your eyes see how it evolves.
Yeah. Well, for our clinical trial, we have to enroll about 80 patients, 40 for each arms, but we expected to reach this trial population quite quickly because this kind of tumor in Tuscany, we have the coast, we have a lot of skin cancer, so I think it's a realizable goals for first clinical trial. In fact, we choose this tumor for this reason and not other, for example, melanoma cancer. And I think could be some important improvement also in the clinic for this kind of patients, because usually are elderly patients, have a lot of logistic problems. So if we are able to treat with one fraction, could be very advantageous for these patients, and maybe with a few toxicity. But for this point, we are not confident enough with the results in elderly of flash radiotherapy. But we'll see.
We'll see. I think as a clinician I can say that the big competitor is a surgeon, whereas when I was in residency training we treated every day several patients with skin cancer, and nowadays the surgeons cut all tumors away unless it's really not feasible. So the patients that we see with skin cancer often are absolutely not eligible for this trial. And what I would like to see is that the results are such that we can go to the surgeons, look, now we have a treatment which is even better than it was before, more convenient for the patient, and please don't stop operating everything which is even beyond logical clinical approaches. Other questions? If not, Giuseppe, I propose that you introduce the winner. So in May at the ESTRO Congress we announced the contest who individual, but of course a team behind, would be the first to start with a clinical device. And as promised, the announcement would be at FRPT.
And we are at FRPT now, and we are announcing it. So first of all, let me thank all the centers who have participated in this nice context. We have received a lot of meaningful and wise proposals. Nevertheless, I mean, there must be a winner, and so the Scientific Advisory Board was forced to choose. And the choice was the University Hospital of Madrid and the team led by Professor Felipe Calvo as principal investigator. So I am very glad to invite Professor Calvo here and to tell us what he and his wonderful team are going to do with the first IOeRT flash unit. Please.
Very much. Thank you very much. Well, it is a great honor and a privilege to reach this point. We are, as you know, we are a university hospital in Madrid. It's the largest one public hospital in the country. It's an academic hospital. It has the highest metrics in academics also in the country. And it has a micro-environment in between that gigantic activity, a macro-environment for 30 years already on intraoperative radiation therapy with electrons. And that has allowed us to generate a lot of information and to put it together with the ESTRO colleagues for guidelines for new users, electrons intraoperatively, and still a big tradition in the surgical generations of departments. So we are still very active, and we treat many patients, 3 patients per week, more or less, with intraoperative electrons. So in that atmosphere, in that microenvironment, an equipment like this will be a tremendous gift for innovation, for research, and for patient care. There are many models of patients, cancer patients, that are, in my mind, amenable to be approached by flash electrons intraoperatively. Many of them are already a reality. Recurrent cases, patients with marginal resections. From the clinical point of view, we have many models to approach one by one, and it has been mentioned before, with the rigor of good science. I want to make a point here, a small point here. This equipment is coming to a nice hospital, academic hospital, a great group of young surgeons and young physicists and young oncologists, and many other professionals. We are an ecosystem, like the hospital, a mini ecosystem in intraoperative electrons, and we have a very traditional contribution of the biomedical engineers. Our hospital has been given by the Minister of Health the opportunity to open a biomedical engineer residency training program, first in Spain. And we are very happy with it, and they will contribute quite a lot. And the other important point for us is to show you that we will be a very open place to meet colleagues. We are an academic hospital. We belong to the university and the Minister of Health, and we have rotating people all the time. So we are open to the European activities that, together with the scientific committee of S.I.T, can be developed in the future. That equipment is an open equipment for the rest of the institutions in Europe that can work, that would like to work with us. The last thing is that I was born in Madrid, and I have moved around the world a lot, and I'm back in Madrid. I'm very happy to be back in Madrid. Madrid is a very prosperous city, very prosperous region of Europe, and is a proper place to have a technological device that will allow us to do further technological developments. And one small point on the success of this clinical transition is to convince the ethics committee of the hospital that we are going to work on cancer patients not only with pharmaceutical compounds and proposals from a pharmaceutical industry, but also with technology that is a key area of development in oncology today. So we have to be innovative in the way we do proposals, not only to test science, but also to reach the patients, get a benefit from them, and be opening the way for other institutions to understand with the ethics committee how to propose trials and actions in the benefit of patients. We are very happy. The group is a 50-people group altogether with medical physicists, biomedical engineers, the imaging people. I mean, it's really a very strong group that has been working 30 years in intraoperative radiotherapy, more than 2,000 patients treated, more than 1,500 patients published. All of those things are available to you, and we will be very happy to work together with the scientific committee and the other institutions in Europe to make this moment that is speculative a reality in very little time, as soon as possible. Flash electrons in patients with cancer, internal areas, that is something that we can achieve together. Thank you very much indeed.
So thank you very much for this summary, and we are very happy that we can team up again. We teamed up several times before. We announced a couple of days ago to all participants to the contest that they were not selected, except of course for Madrid. But we also mentioned that this is just a start because the intention is to build a group of collaborating departments and to set up clinical research in a real network. So keep tuned. There will be many more machines to come, and we're working on several projects that will facilitate the installation of those machines in the research centers, which, like the example of Gregorio Marañón in Madrid, can really contribute to building the research that we need before transition to the clinical practice. Thank you very much for your attendance. Also to the co-speakers, Fabiola Pachar and Giuseppe Felice, and that was it.
And thank you very much, Philip.
Mm-hmm.